Recording now. So ask away, Monica. What are your thoughts? What are you thinking?
I'm just a little bit stuck in the. I know you've explained it, and I looked at the video, and it's you do an you show an assessment tool. Um, we obviously know that Jane hasn't been diagnosed, but there's a possibility of bipolar or schizoaffective disorder,
Hmm.
and we're looking at the, you know, recovery-oriented intervention strategies. And in that, I know we've done uh, a workshop, week 6, I think it was, and it's got material in there, but I'm a bit stuck because since she hasn't been diagnosed, it's basically, and I know we're not supposed to do case management, but suggest the intervention that would be suitable for either of them, or we just go in general with the strategies of empowerment, collaboration, what mental health should be doing from get-go. So that's where I'm a little bit stuck. I know that we're not supposed to do case management, but suggest who should be involved in her recovery, the informal and formal supports as well. So, but that's the one bit I'm stuck. Do we assume that she would be diagnosed with either, or we just take we take an assumption that if she gets diagnosed with bipolar, this is the treatment that it would be suitable for that particular diagnosis, or if she's diagnosed with schizoaffective disorder, this would be the option. Both of them are very similar in the sense that you could choose a certain treatment, a certain intervention, but is it pointing out at the recovery focus of it, like empowerment, um, getting her involved, realizing her diagnosis and all that. Am I going in the right path, or I'm a bit stuck there?
Yeah, you're
It's a
certainly
long
going in the
question.
right path, and but you've unpacked that really well because it's got me thinking about where you're thinking on this task too, and because she hasn't been diagnosed, and many of the clients that we will be working with have not been diagnosed either. So if you were working with someone that you felt did need a diagnosis, what would you do? What's probably the first thing you would do?
I can give you an example. It was just trying to get someone to the NDIS. Obviously, the client's been turned down. The diagnosis wasn't enough. But I looked at her historical, and basically there was, during pregnancy, mom did do drink and alcohol, and there's a lot of behaviors that were pointing towards pasty. So basically, my way of going about it was getting her connected with GP, connected with a psychologist to get an assessment done, neurologist. I mean, for MRIs and stuff like that. I know a lot of this stuff don't need it, but that would have been my way of starting an intervention, like some sort of recovery for her, because there is no proper diagnosis.
That's exactly what this task is looking for.
Exactly.
Without sort of giving you complete answers, because there are several answers, but if you're not going to be working with someone that has been diagnosed, or faced with someone that hasn't, excuse me, I've got a frog in my throat. I've been teaching a lot today. Um, you are going to go into a referral process. So those other people that you will be working with are going to be some of those people that we're looking for. So your GP, your psychologist, they'll be the formal contacts, and you look towards their family or friends to see what type of support they can provide. So your interventions aren't going to be therapy. They're going to be mostly client-based thoughts and supports, and the basic level stuff. Does that make sense? I don't want you to go too far into say, you might say to her, it looks like you're experiencing potentially some depression. Can I do this questionnaire with you? And you might do the K10 with her, and it might come out that, yep, she really does need to see a doctor. So you'll do a referral, and you'll work with the doctor, or potentially even go to the doctor with her, to help. And that in itself is an intervention, supporting her to the doctor, to ensure she gets there, especially if she's got a history of not going to the doctors, or following up on appointments, for example. So it really just is that, on the ground support that you would provide without going into deep diagnosis or suggesting therapy. You may want to say to her, or may have a discussion with her to say, look, I reckon if you go to the doctor, they're probably going to suggest that you see a psychologist. Psychologists might suggest some cognitive behavioural therapy, or you may receive some medication. But let's get you to the doctor first. And are you happy for me to come with you, or do you want me to come with you? Can I keep in touch with you? And discuss with the doctor in the best way I can help you. That's the type of stuff we're looking for here. Does that help? I think you might be overthinking it a little bit, but you're on the right track. You're certainly heading in that direction. But I think you're looking for something bigger than what we're looking for, which might be a relief for you.
Yeah, well, I already said that. I think I'm gonna have to retract.
Oh no.
Or maybe I'll leave it there and just jump off away from it. I still got about 300, 400 words, so maybe I can just try to answer the other stuff.
Yeah. And look, you can pad some of this stuff out. I think what's important, and something I sent an email to a student today who's here. I don't know if it's been seen yet, but we're looking at you applying this stuff to the person, not just general, this could happen or this could happen. What do you reckon is going to work the best for the case study? And that's probably too where your word count will come from, because you could come up, if you want to get really high marks, you could say, well, this is what's generally used, but for this client, this might be the best thing to support her, and then think about it from that angle. But come back to your rubric when you're looking for what you need, and also think about not getting too far into the diagnosis, or putting that label, or suddenly getting her sorted out with a label of some sort, because that will take you too deep, and that will move you into that case management stuff too. Save that for next task. But get this one out of the way and get a break first. Can you see the steps that we're going in?
Is it okay if you just put a link to the assessment tool, or do you actually want a copy of the assessment tool?
No, a link will be fine.
And I don't know, because I'm kind of new to this. Sometimes I put my foot in my mouth. Like, would you be mentioning some sort of reduction of drug use? Is that offensive to clients, or
Say that again, Kristen, sorry?
do you bring that up in is it offensive when you're meeting with the clients to mention maybe they need to reduce their drug use? Is that something you say to people, or
look, it totally depends on
you just don't even.
Totally depends on your rapport with them and why they've come to see you. If you feel someone's using too much and it's interfering with how you can help them, they might be easily able to. I would easily say, have you thought about reducing your intake? But you may approach that a bit softer, if it's your first appointment, for example. But in most cases, they've come to you for help, so it would be appropriate to point out some of the things that you notice. And sometimes it is offensive, but you don't know that until, unfortunately, sometimes till it's too late. But you just gauge the situation as you go along. And I can tell you it's from both sides. I've got it right and got it wrong. But it's very much often how you approach it with the client, how you say it. Does that help?
It's just like raising the awareness of the influence and leaving the decision to the person. Yeah, that's sort of, yeah.
It's education and giving people the information to make their own decisions. So it's informed decisions, especially around drugs and things like that, because we all know drugs are problematic. And no one wants to hear that when they're using them. But the information on how to use safely, or how to reduce, or who to contact even. One of your referrals might be to a drug and alcohol worker, for example. That type of stuff is what we need to be here for.
Do you just pick a few referrals, or you can just go to town with as many as you want, or do you just kind of pick a couple, the most like useful, or?
Yeah, probably. I'd probably limit it to 2, because in this scenario, you could have a whole group of different. You could refer this person, most clients, to many cases, but what's important in this task is you explain why. So you justify. If you're going to send her to a drug and alcohol counsellor, be really clear on why you're doing that, and be really clear on why you've chosen the tool that you're going to use with her and the people you're going to work with. But it'd be good if you could pick, like, refer her to a different organisation or 2, but also work with friends and family and see who her significant others are who may be able to support her too. Other questions have you got?
I've got one more. So
Yeah.
part of the diagnosis, I did jump in there, but because in week 6 we did look at part of the reading. It had a bit of the different therapies, like the CBT, the group therapy, the face-to-face, the psychoeducation, the I've got a mental blank, but there's a lot of the different ways of interacting. Obviously, group therapy, family therapy. So you don't want us to go in that path. You just want us to say this is a referral and this is basically the type of initial intervention, like recovery for Jane.
But keeping in mind that whatever discussion you have with her is going to be psychoeducation anyway. I mean, it's really hard to not be doing that in any situation. So I'd certainly be in this task, be putting some comment in there about how you would use psychoeducation as an intervention. Because it's so easy to forget we're doing this all the time, but we are educating people and that stuff, by saying, your doctor might be referring you to a psychologist who might offer you join group therapy, or you may even want to go to AA or something like that. That's psychoeducation, because you might know a little bit about that, and you're explaining to someone that may not have a clue what's coming up, and might be really scared about what's coming up. So you'll use your knowledge to educate around that.
Thanks.
Good questions, though. Really good questions. Alex, Mavish, Lydia, did you have any questions about the task? Actually,
I think I finished it. I think it's all right.
yeah, it's in. It's in.
Yes, thank you. I think it's okay. I hope.
It's all right. I haven't marked it. I don't mark before the due date. So if you decide after these conversations that you want to make changes, yeah, you can go back in.
No,
Thanks,
I think it's okay. Thank you.
Cool.
Thanks, and I'm on the right track. I asked you a few questions last week, so I've understood. Thank you.
Awesome. What about you, Alex?
The questions that have been asked have kind of cleared it for me. I was in the same boat as Monica. I was kind of steering away into case management because I could not work out what is the direct path, because I cannot say that they have a diagnosis yet they're not diagnosed. I can only talk about presenting symptoms and things like that, but not going full into a diagnosis. And as Kristen was asking, do you want the assessment completed and attached in the assessment, or do you want it separate as a link?
Oh, yeah, look, a link would be fine. As long as I can see what you've looked at, I'm happy to do that. If you want to go ahead and complete one and add that as an example as well, I'm happy for you to do that, as long as I can access it in some way or another to have a look at, in case you find a tool that I haven't used in the past or something new that's available, or something that I think you may have misunderstood. As long as I can access it, I'm happy with that. But if you want to have a play with them and have a practice at using any of them, by all means do that too and submit that if you want to.
Thank you.
But well done. It sounds like everyone's on track. Sometimes though it's really easy to miss the obvious simple stuff, and try and overthink things. But you all do the right things by checking and asking and letting me know how you're tracking. So good luck. And everyone was on track last time. You always have been. I can't see why you wouldn't be this time. But if you are worried, you know how to get in touch. And if you do at any stage have any trouble submitting, like you can't get into the assessment folder for some reason, please email me because sometimes I don't know what happened with the one this time, but it just wasn't available to be opened. So yeah, thanks Lydia for letting us know. And if that did happen too, like if you got to Sunday night and it was due and something you couldn't submit, you wouldn't be in strife for that because that was an error from our end, of course. So look, I only got a little bit for you tonight, and I think the time has been much more worthwhile discussing the assessment, but I did want to touch a little bit on one of the tools that we have had that we have access to. I'll share my screen and I'll also find a link. I haven't put this tool in your content because it's quite medical. But I'll pop it in if you want to have a look at the whole document. But the tool in it, where's our chat? Is okay. It's a New South Wales health book that helps us work with or is designed to help people in nursing mostly, and the medical profession work with people that are using or have used drugs and are also experiencing mental illness. So it really focuses on the comorbidity side of things. And we've been looking at tools. We tools that we can use to support clients, but sometimes we get lost in all the different tools that are available. And no doubt you guys already have in your exploring. And we can always wonder what tool is the best one to use. Is that's something that you might have already been experiencing? Like, oh, God, out of all this stuff I found, which is the best one? Or are people still thinking, God, I still don't know what tool I want to use? It's often one way or the other. It's overwhelm or underwhelm. But whatever tool we use when we are supporting clients, it needs to be a validated screening and assessment measure. Or an intervention. And that simply means it's got to be evidence-based. But what we do, or what do we do when our mental health clients are also using drugs? And often we can really, we like to think it's the medication, and especially this week, the relatively straightforward process of prescribing drugs for mental illness. But then when you add other drugs, we're looking at self-medicating and we're looking at comorbidity. And we've looked at comorbidity before. We touch on it again a little bit this week. But this is a tool in this big document that can help us really think about how we get back to that screening tool. And what we do, if somebody is, we're presented with someone that has that isn't using any drugs, which would be much easier for us. Someone that's using a little bit, or someone that has a severe substance use disorder, for example. So it gives us a bit of a framework on where to go. So I thought we might have a look at a couple of case studies and just really brief ones, just to get our head around how this tool can help, because what we do and some of the interventions we choose can be based on so many different things. And I don't know about you guys, but I love these little these that give you steps and ideas on where to go. Because for this one, if someone's presented to you that has a mental illness of any sort and are not using drugs, you use whatever usual treatment in your workplace. So that could be, something. It could be referral. If you're in a mental health service, it could be counselling, and you'll do that, and you'll just monitor for changes. But you'll keep thinking about the tools that you can use to support that person, and it will simply just go in circles, really. You'll be treating. You just sit here, and then you'll just check. But if someone's using drugs and alcohol, and also have a mental illness, there could be some more things that you need to think about. And that's going to depend on whether or not the person has a significant potential addiction or a severe disorder. And I just wanted to see how you go with these really brief case studies to sort of unpack using this tool. So this is Alex. Alex is 32, and it's not Alex that we have with us today. Trying to use a generic. It's either Alex or Jane. I can't remember who the other names are I use, but I try and use the common ones. So this is Alex, and he has struggled with unstable moods for most of his adult life. He likes a few beers with his dad at regular barbecues that he has with his family and in his 20s. But he's experienced periods of extreme energy and productivity, followed by bouts of deep depression. And during manic episodes, Alex would work hard for days without sleep, feeling euphoric and invincible. But these periods were often followed by quite depressive episodes where he found it difficult to get out of bed. Also experienced feelings of hopelessness and withdrew from family events. So stopped going around for a barbie and having a beer with dad. 4 years ago, he was diagnosed with bipolar after a particular intense manic episode, which led to some really unfortunate financial decisions, and the end of a significant relationship. So if Alex came to you experiencing bipolar, where do you think he would be on this list of, or on these options of drug use?
Oh,
Keep that kid quiet. Baby Huey's like nails with chalk.
Lydia.
sorry about the TV in the background. No, probably the first one on, hang on, I might just. Oh, sorry. I should have read it
No,
properly.
you're right.
Well, he doesn't appear to have a illicit substance use, present. He appears that he may have, bipolar.
Yep. So he's
Um,
definitely come to us for something
so
around
no,
mental health.
Yeah, so no problematic substance use. Treatment as usual, universal screening and assessment using validated measures. Yeah. That's what I think.
Absolutely. Has a few
Yeah.
beers with his dad at barbecues, or has done. But that doesn't mean he's got a problem with alcohol. Just likes a beer with dad barbecue. So if we were working with him around anything to do with his mental health or mental health challenges, that wouldn't be an issue. We wouldn't need to start thinking about what do we do here, because he's got issues with drug and alcohol as well. So we just follow whatever normal treatment that would be. If you're a mental health counsellor or community worker, you would just do whatever your organisation employs you to do. And you'd monitor that while you were working with him. Well done. What about Sarah? Sarah has struggled with anxiety and depression for several years. And recently she took a turn for the worse with the mental health when she lost a job. So she started using marijuana, alcohol as well to help cope. And what started off as occasional use soon escalated to daily consumption. And her drug use exacerbates her mental health issues, and creates a cycle. She's experiencing increased feelings of hopelessness and difficulty managing her daily responsibilities. And she said to you that she relies on the substances to numb her pain. She was hesitant to acknowledge her addiction, viewing it as minor issue compared to her anxiety and depression. So where do you think Sarah would be on no use, mild to moderate, or experiencing a severe disorder around drugs and alcohol? Lydia, you're rocking it.
Oh yeah, I'm on the ball tonight. I'm going to go to mild to moderate. I mean, she does have drug and alcohol issues, but I wouldn't say it's severe at this point. I mean, it's problematic, and it's definitely not helpful to a mental health condition at all, and it's created a vicious cycle. But I
And
still wouldn't put it in a severe category.
yeah, and keep in mind too, you're not diagnosing here. This type of assumption is always based on your knowledge around what you know and your job and reasonable assumptions and any guidelines you would have at work. But it's a really fair assumption because, something you hear a lot of is people don't want to acknowledge that they've got to that point. And they've often come to you about anxiety and depression, because the drug and alcohol isn't much of an issue because it calms you down type of thing. So you're spot on in this case, probably mild to moderate. I hate the word disorder, but they use it in this guide. Mild to moderate drug and alcohol use or substance use disorder. So in this, not only you do your treatment as usual, But in that, you would also ensure it was holistic, and you'd be thinking about all the possible types of integrated treatment. So you might not use just one type of thing. You might use motivational interviewing in addition to some other process or education, psychoeducation. So you'd be thinking about that bigger picture and drawing on a whole number of tools in your practice, but you might also be thinking about how can we give her a little bit of information, just brief intervention about how drugs and alcohol also interact and can make things a lot tougher for her at the moment. E-health interventions, so you may think about different things that we can do electronically. You may refer to the comorbidity guidelines that are linked in with your content that you're aware of. And again, you would monitor improvement as you would with someone that wasn't in this situation. And if everything improved, you'd monitor aftercare potentially. But if there was no improvement, you'd be thinking, okay, maybe we better get some more professionals in and get some referrals happening. You may even do some referrals up here, but serious referrals here if there's no improvement. Is that making sense? And does that look like a reasonable guide for someone that you've considered has a mild to moderate substance use disorder? Yeah. Okay, one more. This is John. John's 45, has struggled with mental illness for most of his adult life, diagnosed with severe depression at 21, often felt isolated and overwhelmed, and despite several attempts at therapy, John's found it difficult to manage his emotions and maintain a stable relationship or even work. Seeking relief from his emotional pain, he began using alcohol and marijuana, which eventually escalated to heroin use by his late 20s. As John's addiction worsened, he became disconnected from his support systems, losing contact with his family and friends. His drug use fueled his depression, creating a vicious cycle where he used substances to cope with emotional fallout, only to feel worse as the effects wore off. John's physical health also declined, with multiple hospitalisations due to overdoses and infections, and eventually John's mental illness and addiction became so severe he was homeless, in and out of shelters, and is a high risk of suicide. Where do you reckon he comes here on our list? Nevish?
Yeah, it looks like a severe disorder to me.
Yeah.
Because he is at the verge of suicide. So
Yeah. And in most cases, well done, because we would not in most of our roles, unless you were actually working employed as a drug and alcohol therapist or mental health therapist, specifically with years of training, you would be looking at working with this client in a way that absolutely supported them to move into AOD specific or psychiatry to get that help that is needed. Beyond most of what we would be working with. We'll be here in most cases. In a lot of cases, we may be here, but for cases that there's obviously a severe disorder, and potentially in this case, he may be diagnosed by a psychiatrist as having a substance use disorder in addition to mental health problems. So we'd be thinking a lot about who we could send him to. Our role would probably become smaller, and in other areas, other specialists would have a bigger role in his life. But we play a key part there. Lydia.
Sorry, I think that was a mistake.
Oh,
Sorry.
no, you're right. So I think most of what we're doing and what you're learning this course, as I say, is this area. This is where, for example, we may be working with someone 70, 80% of the time and refer to someone else maybe 20%. But here it would be, we'd become the 20% and these other people would become 80%. But whatever happens and wherever we go and whatever we do, the bottom line is the universal screening and assessment using validated measures. And those tools that you've been looking at as part of your assessment tasks will be good tools to use, but you will change potentially change the tools as people are becoming well, as people are moving into recovery, or as people riding the waves of change. Sometimes you'll use a tool to start with and you'll go back and you'll use the same tool again to see if there's been any change in the tools. But other times we'll need to just simply do a referral to someone well beyond our pay grade, we hear people say quite often. But we'll also become quite familiar with those people and we'll work with them very closely as part of our networking and collaboration, which is what this subject is also about. Because when we're working in the sector, we will know an AOD specialist, we'll know a psychiatrist, we'll know a GP. We won't be directly referring to psychiatrists probably, but we'll know the names of the ones in our local area that are considered to be very good by the clients that we work with, or maybe not so good. And that's all part of our networking and collaboration. I think that was, yeah, look at that. Look at that. So, is that a cool little tool? I know this week we talk quite a lot about what we are planning to do with clients around tools and support and getting that assessment out of the way. But there's also other bits and pieces that we need to think about, like the medications that our clients are going to be taking or self-medicating with. And that was just a little bit where I wanted to touch a little bit more on to think about. Have a look at that guide if you want. You may find some use in it. It could be useful for you, but otherwise, feel free to use that tool at any stage, as long as you remember to come back to those evidence bases all of the time. And I can't get my camera working. Yes, I can. Here I am. Yeah, questions? Well, that gives you an early couple of minutes to work on your task. And if you've been lucky enough to submit it, you get an early minute. It's good to see everyone. If you need me before the weekend, let me know. But I have all the confidence in the world of you guys getting your tasks done.
Thank you.
Thank you. Good
Take
night,
care, everyone.
Thank you.
Thanks.
See ya.
Bye.
Bye.
Bye.